Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to both understand and perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics that we all have to engage with in daily practice. Valvulopathies, cardiomyopathies, systolic and diastolic function and dysfunction, and also the new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in imaging and echocardiography, and I will guide you through clinical cases and talks from my clinical experience addressing a wide range of echocardiography topics. My imaging, the images that you will see in my talks, are all based from my experience in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is not only a YouTube channel, it is also a website, echobyweb.com, where you will find much of the materials I will present you in this channel. So let's have a look. This is the homepage of the website, echobyweb.com. Up here in about, you will find my credentials. Under Atlas, you will find 2 atlases of imaging, transthoracic and transesophageal. It's work in progress. Under Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, the Montgomery plaque classification, and analysis and quantification of the left ventricle, the mitral valve. And then you will also find formulas and calculations, guidelines, references, an example of a complete echocardiographic examination. You will also find here online calculators, which are Excel spreadsheets on the website with which you can interact, and you can make a lot of calculations, stroke volume through the valves, and you can find the indications for valve surgery based on the latest guidelines, European guidelines, and you can find also flowchart for the calculation of diastolic function from the latest recommendations. And this is the QR code with which you can access, for example, if you have a cell phone. The topic of the present talk, which spans over 5 videos, is the echocardiographic analysis of left ventricular systolic function and dysfunction as seen in the real world. This is, of course, a basic approach to this topic, which is quite large. Now, these talks assume that you have a basic understanding on how to perform basic measurements in echocardiography and mode 2D, pulse Doppler and continuous wave Doppler interrogation of intracardiac flow, and also how to use myocardial tissue Doppler. And it is also assumed that you know how to perform the basic echocardiographic measurements. However, you will find in the website that I just presented to you, echobyweb.com, that I've just mentioned, a large quantity of material, educational material, which can guide you in measurements for examples. And this is the outline of this talk on left ventricular systolic function. We begin with an introduction and definitions, then we move on to physiopathologies and define the determinants of systolic function. We analyze the pressure volume loop as constructed invasively, and we see how invasively we define left ventricular contractility. When we move on to the aims and the qualitative evaluation of left ventricular systolic function, and then the mechanical function of the left ventricle through ejection fraction, and how to perform stroke volume assessment and cardiac output. And then we have the echocardiographic estimation of left ventricular contractility using isovolumic phase indices like the noninvasive dP on dt from mitral regurgitation and the myocardial performance index or TEI index. And we end with the analysis of left ventricular longitudinal function using tissue Doppler, because strain analysis will be the topic of a whole new another video. And these are how they are grouped in the 5 videos. And this is video number 1, from introduction to the physiopathology and the cardiac cycle. And this is the information provided by echocardiography today. The possibilities within each of these categories have expanded with the advancements of research in echocardiography and expanding technology. Now we can consider the information provided as a stratification of different levels of knowledge. We begin at the fundamental level with 2D morphological analysis, and where we examine, for example, the anatomy and the geometry of the cardiac chambers of wall motion. This is followed by 2D functional analysis with 2D Doppler and Doppler ultrasound with measurements, for example, of ejection fraction and Doppler stroke volume, which are also the topics of our talk today. We then move on to Doppler color flow analysis. We can see the direction and the magnitude of blood flow, for example, intracardiac regurgitation and shunting. And finally, we have the most sophisticated analysis, non-invasive hemodynamics, which allow us to estimate pressure gradients and possibly also absolute pressures within the cardiac chambers, and for example, pulmonary systolic pressure and pulmonary wedge pressure. This progressive analysis, which is provided by a complete echocardiographic examination, allows us to answer diagnostic questions, perform prognostic stratification, where currently most of the literature focuses on this, and then we can monitor specific morphological and functional parameters, for example, in response to a specific therapy. Ease of access, portability, reproducibility of the echocardiographic examination guarantee effectiveness in this area. Finally, it is possible to perform screening and epidemiological studies. Some professionals argue that all this information here on the left is excessive, too complicated, and therefore unusable in a routine diagnostic examination like in the community setting or in a busy tertiary care setting. It is, however, crucial to understand that obtaining this information does not require the continuous performance of complicated calculations. Rather, most of the information can be extracted from the images that we acquire in a quick qualitative manner, as we will see. The more complicated calculations are performed when necessary, for example, to quantify more than moderate mitral regurgitation and thus to indicate indications for mitral valve surgery, for example, a frequent case. In this case, the necessary time must be dedicated to comply with the guidelines, and especially for the benefit of the patient. To do this, however, it is necessary to understand all the information that is included in a 2D view or in a pulse or continuous wave Doppler profile. Now, if you stop and think for 1 minute at all the information that is included in a complete echocardiographic examination, then we can really say that the echocardiographic examination can be a one-stop shop for outpatients with heart disease, suspected or diagnosed. We can analyze left and right ventricular, global and regional function, and left ventricular geometry. Well, you need a 3D probe to analyze the geometry of the right ventricle. We can analyze thickness, echocardiographic characteristic, thickening and motion of the myocardial walls. You can easily quantify the heart volumes, ejection fraction, wall motion, score it, stroke volume, and you can use echo contrast when the cavity is difficult to see. And of course you can perform, and this is not, unfortunately, it's not done frequently, but you can perform a complete hemodynamic examination with intercardiac pressure analysis. You will find more of this about this in the talk on diastolic function on this channel. Now you have your patient on your examination bed. This is where you begin gathering very important information. Arterial blood pressure which you should know from patient history or measure at the moment, gives you left ventricular afterload. And the knowledge of heart rate brings you to cardiac output. By looking at the jugular veins, you can estimate the venous pressure, for example. An EKG trace should always be on your echocardiographic monitor. No EKG qualifies an echocardiographic examination as low quality, and you don't want that. And the EKG trace, even the single trace on the monitor, gives you a ton of information on rhythm, for example, the presence of AV delay, AV block, ventricular hypertrophy, dyskinesia because you see a left bundle branch block, a pacemaker, with which you will probably find some dyskinesis on the right ventricle and right wall motion abnormalities, repolarization abnormalities, and then low voltages. And all this brings you to suspect specific pathologies or problems which you will then search for during your echocardiographic examination, as we said. So you will look better at anatomy, geometry, and wall motion. You will look if you have other indices that suggest hypertrophic cardiomyopathy or amyloidosis, for example. Then the morphological study, the 2D morphological study during echocardiography gives you additional information. End-diastolic volume gives you preload, because preload is the end-diastolic volume. And then looking at walls, at the anatomy of the walls and the geometry, you can measure mass, and you can also guess at the presence of wall fibrosis and geometry of the ventricle. And then function analysis through ejection fraction, stroke volume, longitudinal and left atrial reservoir function gives you access to global systolic function, to tissue perfusion, and global function with stroke volume, early functional abnormalities through the analysis of longitudinal function, and you can start to access also some information on left atrial diastolic function by looking at how the left atrium behaves. And then blood flow analysis with Doppler allows quantification of valvular problems and gives more hemodynamic information on the physiopathology of your left ventricle, on the preload, the filling pressures, and the afterload, for example, the aortic stenosis, and again filling pressures with the function of the mitral valve. And finally, a complete non-invasive hemodynamic evaluation means gives you a ton of information on hemodynamics and diastolic function. Mitral and pulmonary venous flow profiles give you chamber compliance. Pulmonary valve regurgitations gives you pulmonary diastolic pressure and thus wedge pressure. Tricuspid valve regurgitation lets you access to pulmonary pressures. The right ventricular flow outflow profile can give you a hint on pulmonary vascular resistances, and the inferior vena cava collapsibility on right atrial pressures. All this will be discussed in the video on this channel on left ventricular diastolic function. So the central focus of our echocardiographic examination is the quantification of the size and function of the cardiac chambers, and necessarily of the left ventricular chamber as number one. Your essential references are these ones: the 2017 European Association of Cardiovascular Imaging document on the standardization of the echocardiographic reporting, which follows the 2015 recommendation for the quantification of the cardiac chambers down here. The table on the right here from the AACVI document, 2017 document, European document concerning the standard echocardiographic examination, lists the required measurements of indexed volumes, relative wall thickness, mass, and biplane ejection fraction. We have already seen how to measure volumes and mass in the other talk on this EchoBioWeb channel about mass and estimation of measurement of volume. We will now see with this talk how to deal with left ventricular ejection fraction, systolic function in general, and stroke volume. But indeed, we may have more tools that address systolic function as we will see in a minute. But to begin, we must necessarily analyze and understand the basic physiopathology of the left ventricle. Starting with definitions about systolic function, systolic function is defined as the capacity of the left ventricle to generate a cardiac output which is adequate to the metabolic necessities of the body. The pump function, the left ventricular pump function, depends on contractility of the myocardial tissue sarcomeres, structure and geometry of the left ventricular cavity, the function of the valves, and of course the loading conditions that we'll see in a minute. We will focus today just on contractility and loading conditions. But we must also take into account the overall pictures and thus also the other cardiac chambers, especially the right ventricle, and the arterial and venous pulmonary circulations. We are mentioning here, for example, aortic impedance, which is also the output, the afterload, of the left ventricle, venous capacitance, which influences preload, and the peripheral vascular resistances, which also influence left ventricular afterload. Myocardial shortening depends on ventricular contractility, the loading conditions, preload and afterload, and heart rate. So if we want to estimate myocardial contractility of the left ventricle with a measure of systolic function like ejection fraction, and when we say analyzing systolic function, what we intend is try to estimate the underlying contractility, we must consider the preload, the afterload, and the heart rate that are present at the moment that we measure systolic function or ejection fraction in our case. To make an understandable practical example, if we want to compare two measures of ejection fraction taken during follow-up at baseline and after a certain therapy, for example after 6 months, to be able to estimate contractility, and if contractility has changed during this time span, we must make sure that the loading conditions, preload and afterload, are similar at baseline and at the measurement made at follow-up, and also that heart rate hasn't changed significantly. And this is because both preload and afterload are independent determinants of systolic function, in our case ejection fraction, and can modify our measurement of ejection fraction independently of contractility. So a change in afterload can change ejection fraction even if contractility hasn't changed. The same for heart rate. Let's look more in detail into these determinants of left ventricular systolic function and their definitions. So, preload. Within the physiological range, preload is a stretching of the myocardial tissue which precedes stimulation, and that determines sarcomere length. And we will see this because it's related, it's the Frank-Starling law. Afterload is the load that the myocardium must overcome to shorten and produce output. The higher the afterload, the higher is the pressure generated, but the extent of shortening is reduced. As this is defined, we will see also this by the end systolic pressure-volume relationship. And myocardial contractility reflects the activation and the density of the bridges between the actin and myosin myofilaments when we consider the ultrastructure of the myocardial fibers. When keeping constant the load, both preload and afterload, an increase in contractility produces an increase in both velocity and extent of myocardial shortening. As an example, the pulse Doppler tissue Doppler technique measures the velocity of local myocardial shortening, whereas ejection fraction measures the global extent of myocardial shortening. And then an increase in heart rate produces an increase in contractility as defined by the force frequency relation. Left ventricular systolic function, the function of the left ventricle, its contraction, is influenced by the geometry of the myocardial fibers and their arrangement. When we consider the arrangement of the fibers and their influence on the contraction mechanics, we have to consider three levels: the ultrastructural level, the macroscopic arrangement of the fibers, and the resulting geometry of ventricular contraction. At the ultrastructural level, the activation of the actin myosin bridges causes the fiber cells to slide over each other. At the macroscopic level, the sliding translates due to the different arrangement of the myocardial fibers: right-handed helix in the subendocardium, left-handed helix in the subepicardium, and a circumferential arrangement in the mesocardium. The arrangement of myocardial fibers comes into shortening along different vectors: radial vector, circumferential, and longitudinal. We also have apical torsion, which can be analyzed with echocardiography using deformation analysis, but is kind of complicated. It's certainly not part of routine examination. Now, ejection fraction, our main analysis, my main measure for left ventricular systolic function mechanics, measures global function. So it is the result of these different vectors: radial, longitudinal, and circumferential fiber shortening. Whereas the analysis of longitudinal function with M-mode, like with MAPSE at the mitral annulus level, TAPSE at the tricuspid annulus level, or tissue Doppler at both, or using deformation or strain analysis, measures by definition only the longitudinal vector. So it cannot be used as an alternative to ejection fraction. It is complementary, as we will see. So it must be clear that the analysis of longitudinal function is not a surrogate for global function. I'm saying this because some authors have suggested to use longitudinal function because it is more reproducible and more easy to do, to substitute it for ejection fraction, but there are two different ways of measuring different results. One measures global function, ejection fraction, and longitudinal function is only one of the vectors of global function. But longitudinal function, its assessment has a specific area of use, and we will come back to this later. We must also consider that the left ventricular systolic function is connected to diastolic function. They are in fact connected in multiple ways. Diastolic function produces left ventricular preload that is ejected by systolic function to produce cardiac output. This simplified diagram relates diastolic and systolic function to each other. Specifically, it shows the connection between contractility, the underlying determinant, the main underlying determinant of systolic function, and relaxation, which is one of the two determinants of diastolic function, the other one being chamber compliance. At the ultrastructural level, contractility and relaxation are like two faces of the same coin. Both are active, energy-dependent phenomena. Contractility involves the formation of actin myosin bridges during systole for feeble contraction, while relaxation involves the breakdown of these bridges, which begins towards the middle of systole and extends into relaxation. In general, a pathogen that alters contractility can also alter relaxation. This is why it is unlikely that there is a pure systolic or a diastolic dysfunction, isolated systolic dysfunction, without the other component of global function also being involved. Classical pathophysiology has taught us that during ischemia, a reduction in relaxation is detected first, and only subsequently there is a reduction in global systolic function. In this regard, the analysis of longitudinal wall deformation, also known as strain analysis, is teaching us that at least one of the vectors of systolic function, the longitudinal one, begins to decline well before global systolic function, the latter measured by ejection fraction. As concerns diastolic function, you will find in this channel a talk about diastolic function and dysfunction, a talk subdivided in 6 videos, which addresses everything you would like to know about diastolic function. And this is another very simplified flowchart in this case, relating left ventricular diastolic and systolic functions. So blood flows back to the left heart from the pulmonary circulation through the pulmonary veins up here on the left, enters the left atrium. We won't address here left atrial function, which is very important. I will upload on this channel a talk on left atrial function in the coming future, so subscribe to the channel to be informed. Blood flows then into the left ventricle during the first third of diastole because of a pressure gradient between the left atrium and the ventricle. This pressure gradient is created by active relaxation, which, as we have said, is connected to left ventricular contractility. Both contractility and relaxation are energy-dependent processes which involve the formation and breakdown of actin myosin bridges at the ultrastructural myocardial fiber level. The filling of the left ventricle then continues in the latter 2/3 of diastole, determined by passive myocardial compliance, until it reaches end-diastolic volume here. This is left ventricular preload, which, through the Frank-Starling law, is one of the determinants of stroke volume. The other main being afterload, up here. That is the resistance to the left ventricular outflow. And the cycle starts again. Speaking of cycles, this is the famous cardiac cycle. In addition to the knowledge of the laws that govern the contraction and relaxation of the myocardium, it is imperative when using echocardiography, even in routine studies, to have a detailed understanding of the timings of the cardiac cycle. This graph shows a synchronized top to bottom overlay of the following time curves: aortic pressure, LV left ventricular pressure, left atrial pressure, pulse Doppler or transmitral flow, and left ventricular volume down here. The timings and durations of the systolic and diastolic phases of the cardiac cycle are shown here below. According to the classic clinical definition, we begin with MC, mitral closure, then we have isovolumic systolic contraction, then we have aortic valve closure, left ventricular ejection time, and then we have aortic valve closure, isovolumic ventricular relaxation, mitral valve opening, and then we have left ventricular filling and its 3 phases: the early rapid filling, the first third, then we have diastasis if the heart rate is less than 80, and then we have atrial filling, and then mitral valve closure at the end when the cycle starts again. We make the cycle begin arbitrarily with systole, with closure of the mitral valve here, caused by the rapid rise here, in left ventricular pressure following the beginning of myocardial contraction. Systole has 2 phases. We have isovolumic contraction here, and then we have ejection, the ejection phase, with closes, which ends with the aortic valve closure, when pressure starts to fall in the aorta, in the ventricle below the pressure in the aorta. Then we have the rapid fall of ventricular pressure during the isovolumic relaxation phase, and then the ventricular pressure falls below left atrial pressure, which causes mitral valve opening. At this point, we have diastolic filling, but diastole, of course, has 4 phases. The first one is the isovolumic relaxation phase. And then after mitral valve opening, there are the 3 filling phases. The rapid filling phase is driven by the rapid fall in ventricular pressure below atrial pressure. There is a gradient that determines the early filling period. Then the pressures, ventricular and atrial pressure, tend to equalize, and diastasis still sees some flow from the ventricle from the atrial to the ventricle. We will see that in the talk in diastolic function. And then we have atrial systole, which causes atrial filling of the left ventricle that reaches the end diastolic volume or preload. And mitral valve closure occurs again with the beginning of ventricular contraction. And this is the end of video number 1 of the echocardiographic analysis of left ventricular systolic function. Please proceed to video number 2, which will deal with physiopathology, the cardiac pressure volume loop, and qualitative echocardiographic analysis. And you are on the Echocardiography channel, a channel for cardiologists, sonographers, but not only, a channel dedicated to echocardiography in real-world analysis. And see you in the next video.